when we think about migraine patients, we have patients with sporadic symptoms and we have patients with chronic symptoms. And those chronic symptoms we generally think of as patients who have symptoms 15 days a month or more. Almost all of our vestibular migraine patients have symptoms 15 days a month or more. And if you're having that many episodes, you're far better off trying to prevent them than trying to stamp out the fire when it's there.
Vestibular migraine is a form of the disease that dramatically impacts those who live with it, despite absence often of the head pain that characterizes many other forms of migraine. Dr. Michael Teixido is here with us to discuss vestibular migraine and management techniques related to it. Dr. Teixido, welcome back to the Migraine World Summit.
Thank you, Elizabeth. It's a pleasure to be here.
We've had several informative discussions of vestibular migraine on the Migraine World Summit, including a few years ago with you. This year, we're hoping to dive into discussions of management techniques in this type of migraine. But before we do so, could you briefly summarize what vestibular migraine is for those who might be newer to this topic?
Sure. The vestibular migraine is an atypical manifestation of migraine in which dizziness rather than headache is the cardinal symptom. We know that any neurologic symptom can be created by migraine phenomena depending on what part of the brain is affected. Most commonly, people have visual aura, and a lot of people with visual auras get them preceding a severe headache. But for every person who has migraine with a visual aura preceding it, there are many more who get just visual aura and they rarely ever get a headache. And we call that ocular migraine. Well, vestibular migraine is a symptom of dizziness, disorientation, vertigo that happens in the brain, not in the inner ear, and that is not always coupled with a headache.
And what is the degree of impact of those sorts of symptoms on someone's life?
The degree of impact is hugely variable. For some people, they have an incidental and startling moment of unsteadiness, as if an invisible man has just pushed them. Others have a long-lasting spinning. Others have a problem coordinating the vergence of eye information and balance information from the inner ears, so that when they move their head, the brain is getting a difference in the signals from the eyes about how much movement is happening and the inner ears. And so they become very sensitive to head motion or any motion. Some patients with vestibular migraine can have unusual symptoms like rocking back and forth, a sensation of constant falling, or a sense that they are displaced in space, as if I am looking at you now and looking at my room. But imagine you feel that you're really looking at the world from about a foot or two behind where you are, an out-of-body displacement. We call that Alice in Wonderland syndrome, as if you have shrunk down and the perspective from which you're viewing the world is changed. So that kind of displacement in space, rocking, constant falling, those are not symptoms that can happen in the inner ear. Those are symptoms that generate from abnormalities of processing of normal vestibular information in the brain that comes from the inner ears.
Well, and that brings me to a question about the fact that we've heard that in migraine, symptoms can generate from the cortex, from blood vessels, from brainstem centers. So where in the brain do then those vestibular migraine symptoms originate?
Oh, well, that's a very interesting question. As you know, it can generate from any of those places. Let's talk about each one. We know that when a person has an aura, that usually the aura generates from waves of electrical activity over the surface of the brain. We call that the cortex. And we know that the auras are most commonly in the visual area, but they can be anywhere over the surface of the brain. So some patients, as an aura, they will have aphasia. They'll know that they want to say something. They just can't make themselves say what they want to say. And that's because they're having aura over the speech area in the left side of the brain. If a patient has aura over the sensory strip, then they may have a sense of migrating numbness that goes over one half of their body. If it's on the other side of the cortex, then it'll be the other half of the body. There are some patients with familial hemiplegic migraine who have a very characteristic aura that goes across their motor strip, and they get actually a migrating paralysis that involves half of their body. Fortunately, it only lasts about a half an hour or 20 minutes. It goes away, and then comes the big headache. So you can get dizziness from migrating electrical activity called spreading depression over the vestibular areas in the brain on the surface. The big question is, where are those areas? There is not really one discrete area that is just for balance on the surface of the brain. It seems to be very widely distributed. So it's not too unusual for patients who are having aura to get little vestibular symptoms as an additive symptom to their aura. And but it's difficult to predict precisely just by location. So that's just one way that we can get balanced symptoms generating from the brain.
So to some extent, the symptoms themselves can help pinpoint the location of the migraine-related activity at that time?
Well, they can, and I think that we'll talk about that in a little bit. So especially when we think about the brainstem, if we know that it may be that spreading depression can also happen in some of the nuclei in the brain. And but certainly we know from functional imaging, which is a kind of MRI that shows us increased metabolic activity in certain parts of the brain, that patients who have migraine have increased metabolic activity in the trigeminal nucleus, the nucleus of the trigeminal nerve, the nerve that is hyperactive in migraine. But it's not only the trigeminal nucleus. There are many other nuclei, and many patients have other nuclei which become hypersensitive. And if they are hypersensitive, then the incoming information from the 5 balance triggers in each ear, 3 with the semicircular canals and 2 with the otolith organs. These are the little organs with otoconia, ear stones that orient us to gravity. That information can get distorted if it goes into a vestibular nucleus that is highly active. Just the way a patient with migraine pain can get something called allodynia. If the nucleus of the trigeminal nerve is lit up and very hyperactive and hypersensitive, sometimes even normal touch, like combing the hair, can be painful. Well, a patient with vestibular migraine with an activated vestibular nucleus may find that just simple motions of the head are exaggerated. And so that's another place that symptoms can generate. Well, we know that some patients, there are lots of ways to get dizzy. Some people with vestibular migraine have a problem that is probably in a portion of the cerebellum. And there's the cerebellum is down in the back part of the head, and it's an old part of the brain. And the center of it is called the vermis. And then down on the bottom of the vermis, hanging down, is a little uvula, just like the one in the back of your throat, the uvula that hangs. And so the cerebellum has a uvula that hangs down, and the new uvula and the nodulus just above it in that midline of the cerebellum are places that the vestibular nuclei send signals to, and then those signals get merged and they get sent back to the vestibular nuclei. And we know that some symptoms can be generated because there's hyperactivity and abnormal processing in that circuit. Patients with this unusual symptom of displacement in space, that is a change in the awareness of our position in space. And awareness is something that is unique, a unique part of consciousness, and it happens in a part of the brain called the thalamus. And so we think that there may even be abnormalities in some people in the thalamus where these signals get sent after they get processed in the vestibular nuclei and in the cerebellum centers I mentioned, the nodulus and the uvula. And so if a patient may have different patterns of abnormalities. And what we're hoping is that in the future, we may be able to subcategorize patients with vestibular migraine and identify where their abnormalities really are so that we can have specific treatments that target patients who have different patterns of disease.
Very interesting. Many patients with vestibular migraine have recurrent BPPV and Meniere's disease. Is there a relationship between these pathologies that happens in the inner ear and vestibular symptoms that occur in the brain? Is there such a thing as a cochleovestibular migraine that could also be present in vestibular migraine?
The fact that patients with vestibular migraine also with an unusual frequency have problems in their inner ears tells us that it's quite likely that migraine changes that happen in the brain, especially with blood vessels and the secretion of inflammatory mediators that are like a venom around the blood vessels. If those blood vessels in the inner ear have the same chemicals and the same innervation, then the inner ear can potentially be affected by migraine activity if the patient's pattern of disease happens to involve the inner ear. So we know that migraine has a prevalence in the United States of about 13% in the general population. But among patients who have Meniere's disease, the prevalence of migraine is about 55%. And those patients who have bilateral Meniere's disease, well, they have an 85% migraine incidence. So we think that in some of those patients, the Meniere's disease may be a downstream effect of potentially an injury of the delicate inner ear by migraine mechanisms. So Meniere's disease for some people may be a complication of migraine in an individual who is susceptible. And the same thing with BPPV. We know that there are more females than males that have Meniere's disease. We know there are more females than males that have migraine. We know that there are that patients with Meniere's disease are particularly susceptible to caffeine and weather change and dehydration and many of the triggers that we think about for migraine. And in fact, in practical terms, one of the things that we look for when we see a patient with Meniere's disease is migraine present? And should we be treating the migraine and see how much the ears calm down before we suggest any solutions for their Meniere's disease, which are destructive? And some of the times we do use destructive procedures, like we weaken the balance nerves to get rid of vertigo attacks. So this is a very interesting question, and there's a lot of discussion in my community about whether these patients who might have an inner ear manifestation of migraine should be included with that group of vestibular migraine patients, or does vestibular migraine really mean just those patients who have migraine related vertigo that comes from the brain alone, but not from the inner ear? But there seems to be a spectrum, and we're studying more, even BPPV. How in the world can otoconia, little crystals in the inner ear, become dislodged by migraine? Well, they seem to. There's a female to male prevalence of BPPV, and there are many patients with BPPV, about a third, who say that their BPPV episode starts with a large migraine episode. So that's about a third of patients. And we have patients who have recurrent BPPV and they do have migraine, and their recurrent episodes of BPPV stop when we treat their migraine. So if you have migraine, you're about 7.5 times more likely to get BPPV than someone who doesn't. So there's pretty strong correlation.
So it seems very important to know everything that you're dealing with so you can make clear decisions about what to treat first.
Well, that's right. Now think about this historically. How is it possible that in 1856, Prosper Meniere, who described Meniere's disease, asserted in his original article that isn't it likely that these episodes, which are so much like migraine, could be caused by a similar disease? And it has taken us a long time to circle back around to that original guidance. And why? It's because when a patient with vestibular migraine comes to us and they have vestibular migraine, which is recognized today, but wasn't recognized 30 years ago, and they had a little BPPV, well, everyone just treated the BPPV because the BPPV was what they could see and recognize. And no one really looked deeper to say, well, they're still not getting better. This is like the worst case of BPPV. And if the patient had migraine and they had Meniere's disease, well, let's just focus on the part we recognize. And so patients got managed for Meniere's disease. And the vestibular migraine component, which we had a perceptual blindness to as a specialty, was ignored. And these patients, of course, had suffered because they fell in a gap in between two specialties, otolaryngology and neurology. And, neurologists are the acknowledged specialty care providers for migraine patients, but they don't really treat Meniere's disease and BPPV most of the time. They come to the ENT doctor. But ENT doctors had not traditionally been trained in migraine. And so they only saw the part of the problem which they were familiar with. And there was no one there to see the whole patient and the whole picture. And thank goodness now there are more and more people who are cross-fertilizing. And so we have neuro-otologists who are otolaryngologists who have a neurology training, and otoneurologists, neurologists who get some otology training. They're right in the middle, and they are expanding awareness of vestibular migraine in all of its forms. And so it's very complicated. I think that patients that really need to get in front of someone who can see the entire problem.
Sure. And hopefully with that crossover, we'll have fewer and fewer people falling into that gap in the future.
Well, unfortunately, there are very few otologists and neurotologists, and vestibular migraine is an extraordinarily common problem, just as migraine is. So what we really need is for more and more awareness to spread out into the entire specialty of otolaryngology. That would bring about another 8,500 soldiers into the battle, and about as many over on the neurology side as well.
Well, Dr. Teixido, you co-authored the chapter on vestibular migraine in the clinical guide, Sinus Headache, Migraine, and Otolaryngologist, and noted that vestibular migraine can respond well to well-established chronic migraine treatments. So let's start with medications, if we can. What are the primary pharmacologic options for vestibular migraine, both for prevention and acute treatment?
Well, I would say that the majority of patients who have vestibular migraine do have a headache history. And the majority of them say, I have had more headache activity since these other symptoms of dizziness came on. Maybe it's a 6-month history, maybe it's a 1-year history. And they respond to chronic headache management. So the basic ways that we treat migraine is to reduce triggers that are in the environment, in our diet, and in our physiology. That means resting, avoiding dehydration, minimizing stress, avoiding hunger, and avoiding manifest food triggers for migraine, many of which are well known. And but also, in addition to lowering the burden of triggers, the ones we have control over, we want to elevate the threshold, stabilize the system so it doesn't get tipped over so easily. Imagine a row of dominoes, and when a patient with migraine has this first domino, and once it goes over, a long sequence begins, and you just have to hope you can interrupt it. That sequence is kind of like a chemical spill. And the earlier, and it is a chemical spill of inflammatory peptides around nerve and around the blood vessels and in deeper centers. And the best way to treat a chemical spill is to stop it as early as possible and not to let it go on. So this is the reason some patients, even with vestibular migraine, at the very first sign of trouble, if they take something, they can eliminate a whole day of misery.
And so that includes any of the traditional medications that have been used in treating migraine acutely, correct? Triptans.
Yeah, that's right. So triptans are pretty good for stopping the release of these inflammatory peptides and also blocking the receptors that they bind to that tip over the subsequent dominoes. So in vestibular migraine, something like sumatriptan is about 50% effective at reducing symptoms in about half of patients. So it's nice to know that you can get some relief, but it's not enough for a lot of patients. So that's a particular problem. What do you do when you're having big episodes now and then that really need management? I think the thing to think about, though, is that most of the patients with vestibular migraine don't just have occasional attacks. When we think about migraine patients, we have patients with sporadic symptoms and we have patients with chronic symptoms. And those chronic symptoms we generally think of as patients who have symptoms 15 days a month or more. Almost all of our vestibular migraine patients have symptoms 15 days a month or more. And if you're having that many episodes, you're far better off trying to prevent them than trying to stamp out the fire when it's there. So we use different kinds of medications to stabilize the nervous system. So what I'm going to describe with these medications applies not just to vestibular migraine, but it applies to chronic migraine headache itself. So imagine, we think that at least some patients with migraine have inherited some defects in ion channels in the central nervous system. Well, an axon is a nerve that has pumped a lot of ions on one side of a membrane and other ions on the other side of the membrane, and keeping them apart takes a lot of energy. And you pump them out through channels. And when you have a nerve impulse, you open those channels and let them mix, and that's a nerve impulse. If your ion channels are a little leaky because of a genetic predisposition to that, then it takes a lot of energy to keep the balance, and you're sitting a little closer to firing all the time. And this kind of explains why a person with migraine has such a sensitive brain. They're sensitive not just to motion, but they're sensitive to light and to smells and to touch and every kind of sensory input. So we have a few different kinds of medications which seem to be particularly effective for chronic migraine patients, and some of them are sodium channel blockers. Those are traditional seizure medicines like Depakote and topiramate. And if you happen to be a person with leaky sodium channels and you prevent them from being leaky, well, then all of a sudden your brain can rest from maintaining from all of that energy of keeping the ions apart. And it's also sitting farther away from firing, so it's less sensitive. Well, maybe that doesn't work for you at all. But when you take a calcium channel blocking medicine like verapamil or diltiazem, or in Europe, they use other calcium channel blocking agents, that might be uniquely effective for you because your problem actually is an inherited problem with leaky calcium channels. It's another kind of a positive ion that is important for nerve conduction. And then there are other patients for whom beta blockers are uniquely effective. And there are other patients for whom serotonin drugs are helpful. And there are lots of different serotonin drugs which have varying degrees of efficacy. But one of the ones that stands out is the tricyclic antidepressants, drugs like nortriptyline and amitriptyline. And those seem to be unusually effective, and for good reason. They not only do they have the serotonin effect that we're after, but they happen to be medium potency sodium channel blockers and calcium channel blockers. And they actually are synthesized from an antihistamine originally. So they have a little bit of antihistamine activity, and we know that allergy is one of those stimuli for migraine, a trigger. And so they have a lot of different ways that they can work. So some of these medications like tricyclic antidepressants are unusually effective because they actually treat using all of these strategies at the same time. The tricyclic antidepressants are giving not only the serotonin effect that we're after, but they happen to be medium potency sodium channel and medium potency calcium channel blockers. It's like giving 3 classes of medication at the same time. And the other nice thing about them is that you can use them at very low doses. They were not very good antidepressants, but in the 60s and 70s, there wasn't anything else available. And psychiatrists would start at 100 milligrams a day and move up higher and higher to 250 or 300 milligrams, sometimes even higher than that. And at those high doses, if you're taking essentially 3 different kinds of medicine packaged into one, you're going to have a lot of possible different side effects. Fortunately, a lot of our patients respond at 20 milligrams or 30 milligrams, and they have a great symptom relief with a minimum of side effects. So most of the time, that's where I start with patients, especially the older they are, the better they tolerate it. So anyone over 50, I start with nortriptyline. But younger patients tend to feel a little tiredness from it. That, they have a lot of general energy of youth, and they're more likely to feel that effect of the nortriptyline, even at low dose. But it is a very good class of medications. There's no medicine that seems to be uniquely effective for vestibular migraine except one, and that medication is clonazepam. Clonazepam is a benzodiazepine. It's a cousin of Valium and Xanax. These medications are direct vestibular suppressants in a way, but they don't work in the inner ear. they work in the brainstem. They work on those circuits between the vestibular nuclei and the cerebellum that I was telling you about. So some patients with vestibular migraine can get great relief with low doses of clonazepam. It's an anxiety medicine. It relaxes you. And as you know, a lot of patients with vestibular migraine, their lives are turned upside down. They have a huge amount of anxiety. For some of them, their problem even is stemming from a peak of anxiety and stress in their lives for a variety of factors. And having at least a temporary reprieve from that reinforcing cycle of stress and symptom generation using an anxiolytic drug that also decreases the intensity of symptoms can give them a little bit of hope and decrease the heaviness of the burden of their symptoms. So that can be really helpful, at least long term in some patients, but in others, it can help them to understand the role of stress in generating their symptoms and give them time to get the right kind of supportive therapy that is so often helpful in some of these patients.
Well, along these lines, some of our viewers have reported that meclizine doesn't help to reduce intensity of their episodes or chronic symptoms, but that diazepam is helpful. And they've noted that in varying degrees, to varying degrees with varying doses.
No, and that's exactly the case. So benzodiazepines like diazepam and clonazepam have more of an effect in the brain than in the inner ear. And the traditional vestibular suppressant medications like meclizine and most of the antihistamines, meclizine is an antihistamine, they are cholinergic and they work in the inner ear. Well, if the problem isn't in the inner ear, then patients will tell you, oh yeah, I took all of that and it actually made me feel worse or it had no effect. And that's a very curious thing because most patients with real inner ear problems, they take something like meclizine and an hour later they can tell that, okay, that really reduced my symptoms by 50%. So when they tell you that at their first visit, you know that you're probably not dealing with an inner ear problem.
How do the newer migraine medications and those in the pipeline factor into vestibular migraine prevention or acute treatment?
Oh, that's a good question. Some of the new medications are antibodies or against a particular molecule called CGRP, which is one of those inflammatory peptides that gets secreted around blood vessels. CGRP may have a role in vestibular processing in the vestibular nucleus. We also have oral medications now that you can take that are not antibodies, but that block the receptors that CGRP stimulates. And those have been really effective at preventing headache, and they're remarkably specific, and they don't have very many side effects.
And these would be the GPANTs?
That's exactly the case. The class of medications called GPANTs are potentially helpful. They're worth a try. In general, a patient has vestibular migraine and they're having severe problems. They're having head symptoms like headache, but not always severe headache, like they have to go lie down. They might just have pressure, like a rainy Monday morning, full head all the time, and this vestibular hypersensitivity to motion, and then episodes where the intensity of that sensitivity goes up and down by hours at a time. And if you treat the pressure as if it were a headache, usually that goes down. But then the more that goes down, the more the sensitivity to motion goes down. So once again, we're treating the entire migraine constellation of symptoms in the same way, but there isn't a specific treatment that seems to be uniquely helpful for these patients. Now, there's an exception to that, and that is, vestibular therapy, which I think that I wanted to make sure that we talked about. can be really helpful for some patients with vestibular migraine. But especially because some of them have some otolith disease. They might have some BPPV. And when they get their BPPV, boy, for everyone with BPPV, they go, wow, I'm really dizzy. That's horrible. But for the person with vestibular migraine, those loose crystals cause symptoms that push all the dominoes down. And if you can identify which canals and which ear those otoliths are in and release them with a maneuver, then you can prevent all of this triggering from happening. And that can be invaluable to a patient with vestibular migraine. Some patients who, if they have vestibular migraine that happens to also involve the inner ear, and they have one labyrinth that has been injured, they may go through a period where one inner ear is weak, and the brain has to learn how to focus on just one, how to fly the plane straight with one weak engine. And so the brain is the pilot trying to learn how to fly the plane straight, take off and land. But and that usually happens pretty quickly with vestibular therapy. But if there's also migraine, then the imbalance causes the migraine to get worse. And the worse the migraine is, the worse the pilot is at focusing on this task. And so a deliberate vestibular therapy to help to compensate for an imbalance in the vestibular function can be really helpful to get them through a rough spot. But we always have to be a little careful with vestibular migraine patients, because they will often tell me that, oh, I went for therapy, and every time I go to therapy, I'm really wiped out. I get home and I lie down on the couch and I'm there for the rest of the day and evening. I'm wiped out. Well, often that's just a step backwards, and that doesn't seem to be getting better session after session after session. And what we realize over time is that for many patients, the vestibular therapy is helpful to keep them moving and to not develop a fear of moving. But that the dose of therapy that they can really tolerate may be 10 minutes or even less than 10 minutes. And it may be that they need to do their own therapy at home, to get coached by the therapist, and then go home and repeat it a few times a day, just in the small doses that they can tolerate. And I think that this is the big point for most patients. They need to learn how much they can insist without paying for it and taking a big step backward. And this way you can maintain boundaries. We don't want to have patients fearful of all movement, and because then they can develop a more of an overlay of a fear of motion, and that some people call PPPD, which I think that is something that there is an increasing awareness of PPPD now, persistent perceptual postural dizziness. And what that is a phenomena where patients have learned to focus on a balance symptom in a way that they never did before, and changes the way they perceive everything. And now they just can't unlock their focus from their balance sensorium. And it may be that they're just interpreting their reality wrongly. And that clearly exists in a few patients. Let me tell you a little story, a little example. Every few months, I meet someone who has an ear infection, and their ear infection comes and goes, but they come to see me months later because ever since that ear infection, they have a click in their ear, a loud click. It's a click that happens every time they swallow. And the reality is that if you swallow and I swallow or anyone swallows and you listen, there's a click in your ear. That's the natural opening and closing of the eustachian tube. Well, it's been there our whole lives. It happens hundreds of times an hour, and it's loud. But we never really paid attention to it. But then you get an ear infection in one ear, and you're all focused on your ear. The ear infection gets better, but now you're noticing the click and perceiving it as a problem for the first time and going to the doctor for it. And so we have to explain to these patients that, no, that is a natural thing. You're just focusing on it. And so some patients can get a balance problem, and the balance problem heals, but they've learned to focus on their balance problem in a way that they never did before. That's what PPPD is. So it's possible for some patients to have symptoms that you can attribute to that kind of hyper focus on the sensorium of balance, our awareness of our position in space. But anybody can focus on it that way. But they've been tricked into that.
To an altered perception of the symptom as something because of what they've recently experienced.
That's right. So now they're back to normal, but because now their perception and their focus is changed, they think that there is a symptom that is ongoing, when in fact they're just have a new way of focusing on their reality. So I think that some patients, unfortunately, with vestibular migraine can be written off as having PPPD. And it's very convenient for the physician because they say, well, if it's PPPD, I don't have to treat it. I'm going to send you to my colleagues who do cognitive behavioral therapy. And those patients are not very well served. I think that patients who have stress, I think it's important for them to have therapy as a part of their treatment. But we shouldn't ignore the definite medical symptoms that patients have. People with PPPD don't have momentary symptoms. They don't have head motion sensitivity. They just have like a constant aura of something not quite right.
We started to touch on vestibular therapy, which I've often heard referred to as vestibular rehabilitation as well.
Yeah, sure.
So what is it? What happens in those sessions?
Well, I think a lot of different things happen depending on what the problem is. And here's where I think that there's a little bit of a gap. And in our training, every vestibular therapist, every therapist feels like, oh, I can do balance. But we know over time that this is a specialized world. Just not all doctors can do dizziness. It really helps to have a special interest in this area to have a greater degree of perception. Too many vestibular therapists do the same thing for all their patients. But what you really want is a vestibular therapist who understands that patients who have otolith disease get specific treatment with repositioning. Patients who have an uncompensated weakness, that is to say one inner ear that's weaker than the other and the brain hasn't learned how to recalibrate to that imbalance, well, they get another kind of treatment to enhance compensation. There are other patients who have a hypersensitivity, and there can be, and those are a lot of vestibular migraine patients. They're really sensitive to head motion. And sometimes by insisting just the right amount, you can habituate and get them to be they have their system react a little less to that motion over time. That is, so it doesn't react. Now, that's a problem because there is a fundamental problem among migraine patients in which they can't habituate. So you have to be really careful. This is where I was saying that the dose of therapy may be really small for some of those patients. And finally, there are other patients who have problems with their balance because their inner ears have gotten really weak. Their gyroscopes, in a sense, have gotten so weak that they just don't have very much balance. And you need to teach them something called substitution strategies, in which they get more information from their vision and they get more information from their proprioception, from their body, their muscles and joints, by using a cane, by taking the big spongy running shoes off of them and putting them in firmer soled shoes so they feel the floor more definitely. This increases their contact with the support surface and improves their steadiness. And also, many patients, they just need to get in shape a little bit. If you're, when we walk around and move around, we're dancing in a way. And you can't dance very well if you're really weak. You're going to fall. And if your body knows that you're too weak to move around, so it doesn't let you move around. And so we end up walking around like we're on a tightrope. And so you need to get people in shape, get them toned up so that they can move, and that their cone of stability, we say, kind of starts to expand, and they can move around more easily without getting near that fall limit.
So vestibular therapy or vestibular rehabilitation is clearly not one size fits all, but needs to be tailored based on the specifics.
Absolutely. And the best kind of collaboration between a therapist and an otologist or anyone, or a neurologist who's helping to treat balance disorders, is driven by the diagnosis, because the physical therapy strategies that you use for these different categories of patients are dramatically different from one another.
And there may be different thresholds of tolerance, as you've pointed out. And in fact, one of our viewers, Heidi, shared that very thing, that some of her vestibular rehabilitation can actually serve to pronounce her dizziness, and wonders if there's a different approach. And it sounds like you've already suggested that, in that it may be smaller segments or smaller exposure to build up a tolerance to greater amounts of time. Is that correct?
Yeah, that's true. So I don't think that it is harmful for anyone, but if it's not giving benefits, then you should consider whether or not it is really going to help at this time. And it may be that it's very helpful, not helpful now, but it may be helpful in the future when the system becomes less sensitive.
Who performs vestibular rehabilitation or therapy, and who should those living with vestibular migraine who are interested in seeking this out really anticipate working with to facilitate it?
Well, I think the best way to do it is to speak with the treating physicians, because they have developed a treatment relationship with therapists. There are about 7,000 otolaryngologists in the United States. Well, there are 230,000 physical therapists, but not all of them have developed a great competency in vestibular disorders. So in any community, there's just going to be a subset of individuals who have a special interest and who are being sent enough patients that they develop a competency. So I think the thing to do is to ask your physician if they can send you to a therapist who has a special interest in these problems. The therapists who I work with, there are about 12 in my community who I send my patients to, and all of them have been to the office here with me and seen patients with me, so that we create a very clear understanding of which patients are going to benefit and how we would approach them. Getting a recommendation from someone who has that kind of treatment relationship is helpful. But most of the patients, most of the vestibular physical therapists who are really interested own a pair of infrared goggles. These kind of goggles allow you to see eye movements and help enhance your ability to do vestibular diagnosis. Someone who has invested the funds and the time to learn how to in this equipment, and has an interest in learning how to interpret eye movements, that's a real mark of someone who is likely to have the kind of competence you need to make sure you're having success.
That's a wonderful tip. Thank you. While we're on the topic of non-pharmacologic approaches. Our viewer, Patricia, noted that she makes a practice of controlling her salt intake and she eats bananas for potassium. That brings up the question, are there any natural approaches that should be part of a vestibular management plan?
Yes, and to the extent that there are natural remedies that are helpful for patients who have migraine activity, whether it's migraine headache or vestibular migraine, there are non-medication approaches. And it's perfectly understandable that many patients are averse to medications, all of which have possible side effects. Non-pharmacologic routes that are the most effective are lifestyle change, including stress reduction and improved sleep. A lot of our patients, nothing works. And then we find out, how much do you sleep? And they say, I only get about 4.5 hours sleep. And I say, really, is that true? And how much time do you spend in bed? It says, well, I'm usually in bed like 8 hours, but I just only sleep about 4.5 hours. Well, how can any brain function well? That is a chronic fatigue is a great stressor. And so there's a lifestyle change and there are many non-pharmacologic, remedies from melatonin to different teas and things like that can help you to sleep. You can take magnesium. We know that patients with migraine have low intracellular magnesium in cases, and you take a serum magnesium level and it's normal. But taking some magnesium of any kind, it doesn't matter whether it's oxide or aspartate or gluconate or citrate, which is a little bit laxative. They're all a little laxative. That can be helpful for some patients. Some patients get better with CoQ10. Some patients get better with riboflavin. And riboflavin, which is vitamin B2, taken at 400 milligrams a day, has as good evidence for efficacy as some of the preventive medications that I spoke about earlier. So definitely worth a try. And if they work for migraine headache, then there's a chance that by ramping down migraine activity globally, that vestibular migraine symptoms will also improve. So it's really difficult to separate the two. And with the exception of vestibular therapy, it's difficult to say that there is a specific treatment that is uniquely effective for vestibular migraine, but that isn't also helpful for migraine headache.
Is there any research in progress around vestibular migraine that you're particularly excited about?
I think that the most important work happening right now is the attempt to define the problem and to subcategorize it into types that allow us to do better research. That means categorizing the disease and describing it. And that sounds like a very administrative sort of answer, but it's important from the top down to create this categorization scheme. It's a little dangerous, though, because when we make these subcategories of disease, people we get taught these in medical school. We memorize them. We have to take tests on these categories. And the same thing happens, say, for migraine headache. What is migraine? What is migraine with aura? And they'll give you a question. You'll say, oh, well, that couldn't be migraine because it's not 4 hours in duration. Those categories are extremely important so that we can do certain kinds of studies, drug efficacy studies and epidemiology studies. If you do those kinds of studies, everyone needs to agree that the people you have counted or the people you have included in your study all do have the problem, no question. But there are many patients who have migraine who don't quite meet those criteria, but who have migraine, and they're going to benefit from the same treatment. And unfortunately, some very officious and studious physicians can use those criteria wrongly as exclusion criteria for treatment. Like, no, I'm looking here. It just couldn't be vestibular migraine because you didn't have 2 episodes yet. that will kind of like fit the mold. Well, you're not doing a study. You are not deciding whether or not to include them in a cohort in a study. So, and you are the person in the trenches there to advocate for your patient. So you would hate to use them as exclusion criteria and a way to withhold treatment. And unfortunately, I think some of our patients have been frustrated trying to find someone to just treat them, please. But now I think this awareness of vestibular migraine has grown, and the need to treat this whole population of patients has emerged among neurologists, and more so among otolaryngologists. And patients are now having some more success finding people to treat them.
Mm-hmm. Where can we best learn about and find out more about what it is that you do and are doing in this arena?
Well, I think that one of the best places is my YouTube channel. And I think one of the things that I'm really interested in is in increasing awareness of vestibular migraine and how migraine in general can generate all kinds of different symptoms, especially in the head and neck, which are important to otolaryngologists. There are a lot of patients who get symptoms from migraine for which they'll go to an otolaryngologist, but they won't go to anyone else. So they have no chance of getting better if the otolaryngologists don't have kind of migraine awareness. And those patients have sinus pressure, they may have tinnitus, they may have ear pressure, and many, many other symptoms. And those are summarized in my YouTube channel. I've tried to collect a variety of different patients with little 2-minute vignettes of unusual symptoms and patterns of symptom. And people will often say, wow, that just sounds exactly like me. And I've also posted a few lectures there that review a current understanding of the pathophysiology of migraine and go into more depth exactly how this migraine pathophysiologic mechanism that affects the blood vessels around the brain, the electrical activity in the cortex of the brain, and the deep brain centers, the nuclei, can create an enormous variation of symptoms. So those lectures are there. There is also a lecture there that talks about migraine and Meniere's disease, which explores the incredible overlap between those two entities so that they can be looked at as variations of the same problem. So I think that would be one of the best places. And another place to look at Association of Migraine Disorders, which is an organization which I co-founded with a colleague, Rick Godley, about 9 years ago. We've hosted a few meetings that try to increase awareness of the huge variation of migraine symptomatology in all parts of the body. So just as I was just talking about symptoms that are common in otolaryngology, we've brought in women's health specialists, GI specialists, cardiologists, oromaxillofacial surgeons. Every specialty has some patients for whom a subpopulation of patients they're seeing are actually having symptoms that are generated by migraine mechanisms. And we're really making an effort to try to increase awareness. So there's a video blog there and plenty of other content that's helpful to both practitioners and to patients.
Good. We'll be sure to post links to both of those then in the show notes with this interview.
Good.
Thank you so much, Dr. Teixido, for being here with us today to review vestibular migraine and management techniques for it. We appreciate you taking the time and sharing your expertise.
Oh, it's really a pleasure, Elizabeth. Thank you so much. I hope that people find this useful.
Thank you.